I'm Professor Stephanie Dimmeler from the University of Frankfurt, and with me today is Hugo Katus. He is professor at the University of Heidelberg, and I think most of you will know him, but who don't, he discovered actually troponin, the biomarker for myocardial infarction and for cardiac damage. He's very renowned in this field for decades, also for many other findings in the cardiac hypertrophy, heart failure field. And I'm very glad today, Professor Katus, to interview you and have the honor to speak with you about the future developments in the field and discuss the possibilities, maybe also visions for the future.
Yeah.
So maybe I can start with the first question. And I mentioned already that you are well known for biomarker research. So is there anything better than troponin, and what we maybe ask for or looking forward in the future? Are there even better biomarkers?
Yeah, first thanks for the very kind introduction. I'm honored to contribute. So your question to troponin could be answered very brief. No, I don't think there is. If you consider biomarkers of myocardial injury, okay, so for the injury topic, you need to have a very specific molecule which is restricted in expression to the heart and which is not present in circulation, and you must be able to detect it with a very sensitive and dependable system. And I do not see any cardiac specific molecule ahead which is which will beat troponin. So there's some discussion on myosin binding protein 3, but at the end, you know, you need to have a dependable measurement system, and so there will be no I do not believe for injuries that we have any advancement in the biomarkers. It's different. It's different when we talk on let's say disease processes. Since that's there, I do believe that molecular diagnostics will have some role to play, and it's there are certainly other biomarkers reflecting different disease processes like inflammation or fibrosis, and so we need to look at this differently. And last word to the biomarker field is there are certainly still needs to be improved. So if you think we have no specific biomarker for brain injury, we have no specific marker for smooth muscle injury, so when you have that gut problem, or even you may know that very well also for endothelial cell. So so that's so there's still open issues, but for the injury marker, I believe troponins will stay.
So you believe that we may become more precise in maybe diagnostic purposes to really dissect different types of heart failure and different maybe also pathological reasons for heart failure with potential new biomarkers?
Yeah, that's a very important point. I do believe when we talk now on heart failure, and also troponin has also a role in heart failure, since it's a good indicator of the severity of myocardial injury and has prognostic implication. However, in heart failure, it's more to really assess myocardial stress at one side, but also to understand the causes. And there, I do believe that we will see quite a bit of evolution in that we have more precise characterization of the diseases. So genomics will play a major role, and you know, and we understand that cardiomyopathies is a very different causes that lead to cardiomyopathies, and I'm deeply convinced that these different causes have different disease pathways activated, and that means that we also need to treat it most probably differently. So I'm convinced that in the heart failure arena we will see more molecular biomarkers. We tested in the past, being convinced of these biomarkers, also the epigenomic profiling in heart failure, since it's not just genomics which determines how myocardial function develops or remodeling processes evolve. So we looked also for epigenomic regulation, and it was also interesting to to see differences in epigenomics. And we tried to study biomarkers on the level of the metabolome. So trying to say, well, the end point of any disease is metabolic disarrangement. There we were a bit disappointed since it was so complex in the analysis. We did find dysregulated complex fatty acids, but it's not specific, and pattern recognition will always be a bit complex and demanding.
So from biomarkers to therapy, what do you see in the future in the treatment of heart failure and cardiomyopathies?
Yeah, as I said, I'm a strong believer that we need to personalize our cardiovascular medicine. We must learn from oncology. They really, when they treat a cancer, knows that it's very different in its makeup. So they do the deep phenotyping, that genomic analysis and molecular analysis, and that then come up with different treatments. So I do believe that we need to integrate in our therapeutic armamentarium also more causal strategies, not only concentrating on remodeling processes. So I believe gene therapies, gene editing eventually may be a topic that we will see. So it's just to give you a glimpse on what is happening. It's now more than 180 startup and big companies working on gene therapy again. So we thought it's a dead business, but it's not. It's still very much alive. And there were more than 25 billion US dollars lately invested again in gene therapy development. So that's a dynamic field. And we have seen some results already in Duchenne muscular dystrophy, but also in hypertrophic cardiomyopathy. So I believe we will be more precise and more personalized and in our treatment strategies.
So thank you for this outlines and visions. Maybe I come to the last point I wanted to cover today, and this is artificial intelligence. May I cite something which you recently presented? You mentioned that in the future, artificial intelligence will not replace clinicians, but clinicians who use artificial intelligence will replace clinicians who do not use artificial intelligence. So I think you are a strong believer in this field, and maybe you can give us some hints what the powerful maybe use of these new technologies is, and how you envision the future in this respect.
Yeah. Oh, I'm deeply convinced that this is similar to the Industrial Revolution. It's just a breakthrough and in the IT technology and in the computational sciences, but also in computational hardware. So today we can manage much larger data sets, and we have these processes, algorithms of deep learning, deep neural networks. So what I do believe is that we will see that we may use more digital data, which rely on very standardized data sets, and that we will, when we do an MRI image, for example, we need not to look at the image and the morphology, but we extract the digital data, and we combine these data from MRI with the laboratory data or with the ECG, and then that's what we did together with Siemens, and do your digital twin. So then you have your heart model of every patient. So we have now nearly 200 hearts in our computer from our patients, and we can model this heart with different exposing theoretically to different ionic conditions, pacemakers, and so on. So that's one application, but it's not just for the clinics. I think it's also for research. So if you think how efficient it was to predict protein structures by this alpha Google computer, which was superior to all other biomedical experts. So there's so much advancement in power of computational power and velocity. So I think that will change. And in the clinical arena, we will not only have more data integration and more complex, but also complete phenotyping, but we will also have that different attitudes that the patient who leaves our hospital will remain connected with us via biomonitoring, via personal interaction. Why? Because he feeds his own data in our computer. So what we will see is that in our hospitals, we will have a medical data integration center. We need that.
So thank you very much. Maybe one wonders whether one needs doctors at all and whether the computer can then treat our patients. But maybe it's a discussion for having a beer together on this. And I'm sorry, the time is running out. So thank you very much for your insightful insights and for your visions in the future of cardiology. And for all the audience, I would also like to thank you for listening to us. Thank you.